Hello. Sorry, we're still having some issues with the microphone of Dr. Schmidt, but we are solving it. So maybe I can start
Yes,
and
please,
present
please.
the case.
Yes, please.
Oh,
Thank
okay.
you.
So, hello, good morning to New York. Maybe we can have the patient slides. Can you hear now?
Yeah.
So, yeah, next slide, please. Next slide. And again, next slide. Okay, so we present a 76-year-old gentleman with severe claudication of the left leg and a walking capacity of 10 meters. The ABI at admission is 0.4, and he had a Rutherford class 5. In 2018, there was performed an endovascular approach with stenting of the left SFA. 2021, he got in the same leg a prosthetic bypass surgery and the TEA of the left groin, which occluded. So in August this year, the vascular surgeons performed the reverse saphenous vein bypass in another hospital, which is also already occluded. He has is on oral anticoagulation because of permanent atrial fibrillation, and the typical risk factors as there are hypertension, arterial hypertension, is a former smoker, has a high lipids, and the diabetes mellitus type 2. So next slide, please. Maybe for the case, I can already pass to Dr. Schmidt.
Okay, yeah, thank you. This is an angiography which we have obtained actually beforehand for planning after all these relatively complex interventions. You can see once again that a long occlusion down to the distal SFA of the stents, 2 bypasses occluded. Yeah, unfortunately, very poor outflow. And next slide, please. Our intended strategy to go crossover, 8 French. We try and integrate guide wire passage with stents re-occluded for
2018, they passed it, but
nearly 6 years, 5.5 years. And surgery 2 times on the groin could be difficult to get in. So potentially also a retrograde approach is necessary. And yeah, I would say now for decades, the Rotarex artery thrombectomy is our device to go through occluded stents. Thereafter, it's planned to treat with the sirolimus-coated balloons, as in the last case, and maybe the next slide. Yeah, so you hear the Rotarex device for those who do not know this. So it's available in 6, 8, and also now in 10 French. Instant is actually for us always 8 French. For iliac instant 10 French. So it's a catheter, very flexible, can go nicely crossover with a tip which spins, rips off the material and the spiral inside of the catheter rotates very quickly, creating a very strong aspiration force. So it works like an Archimedes spiral. And next shows you some data. Next slide. Comparing the 6 and 8 French device, you can, for example, see the max rotation speed is 60,000 rotations per minute for the 6 French and 40,000 for 8 French. And the aspiration volume is actually quite big, at least for 8 French, 75 milliliter per minute. So if you have very small old lady, you have to be careful not to activate it for a too long time, but for a man, usually normally tall man, no problem. Yeah, next shows you, yeah, once again, the magic touch balloon, and I've shown this already during the first case. Yeah, let's switch to the angiography, and Manuela went already crossed over. Can we switch to angio? Yeah, so 8 French. We could also go antegrade down, but after several surgeries here, maybe a little difficult. That is probably the stump into the SFA. Here now the stent here. And then, yeah, the whole length is totally occluded. Cannot see here really a major stent fracture. We don't know which stent this is. That was also done in another hospital nearly 6 years ago. And also distal, an area where there's no stent but native artery occluded. Yeah, further down, complete, yeah, okay. And then unfortunately, as we've shown you, only the peroneal artery open and the foot not so nice here. So definitely we do not want to have an embolization. With this device, with this strong aspiration force, risk is very low. But occasionally, in fact, we work over filter protection. And that would maybe be a good case to do this with nearly 6-year-old material in the stent. It may not be able to thrombolize this if we have an ablation of this material. And therefore, yeah, potentially also take a filter here to treat this. Yeah, we started already here and expecting this to be very difficult. I took here a 5 French Judkins right catheter in, drilled it here away from that collateral, pushed it a little bit, and actually that went into the occlusion already. And yeah, using different angulations, it actually seems to look to the orifice of the stent, which very often can be a big problem, that you directly go subintimal with your wire. The wire always goes around the stent. I expected this to be the case here because of the years of occlusion. We were also prepared here to take a 6 French guiding in, and you see it was very easy here, in fact, to get in. Yeah, unexpected. That's where we are.
So great case, great introduction, Andre. Thank you as always. It's wonderful to watch you do these cases. You make it look so easy. Maybe I can ask the panel here. You know, we have a classic ISR case. We've got multiple ways that we can treat ISR today. Just asking the panelists, you know, what would be your choice here? We've got laser, we've got Rotarex, we've got other devices, we've got data for a lot of this stuff. Maybe we can start with PK and go down.
And quick cross.
Well, you know, I agree. I mean, in terms of that, it's an exciting time because we do have a lot of devices to deal with these difficult lesions. You know, in the beginning with the Excite trial, we were very, for lack of a better word, excited about using laser and have had great success with laser. But the problem is the luminal gain with laser is not quite large, even with their oscillating device. But you know, once we got Rotarex on the shelf, I was telling our colleagues here that the Rotarex, you know, has really changed our practice. We use the 8 French Rotarex in all ISRs, and pretty much have had very satisfactory results. We learned from Andre that you know, after when we first got the device, that we could use filters with it, which is very exciting for us because we worry about embolization, and the filters have also helped prevent any embolization from occurring. So in our practice at Sinai, generally it's Rotarex as a first go-to, followed by either covered stenting or DCB, depending on what we see.
Dann nehmen wir mal noch mal einen harten gebogenen Ton.
Yeah, no, that's a great algorithm, and I think most of us, I mean, if you think of RCTs, right, there's RCTs for DCB, laser, covered stent, etc. Obviously, the numbers are small even in those trials. How many people would use a filter in this case? Obviously, when we're dealing with ISR in the periphery, we've got big vessels. We're dealing with not only intimal hyperplasia, but a thrombus of differing ages, debris, and so forth. So it looks like everybody would use a filter in this case. Would anybody approach this case any differently?
Yes.
How would you do this, Christian? Because this is a patient's been operated on multiple times.
Oh, wait a second.
I wouldn't do it.
Okay, tell me,
I would
Christian.
ask a couple of things. Number one, the risk of limb loss in this patient, the natural history of a claudicator is very different from a critical limb. He has a high-risk outflow. He has failed not just ISR class 5, but also 2 bypasses, one prosthetic and one with vein. So there's something wrong with the inflammatory component of this patient to begin with. Biologically, he's against you. And now you're doing a high risk intervention that is potentially a limb loss intervention when his claudication will not get him loose. So get him on an exercise program, tell the German to stop smoking, and he'll be fine.
No, and that's a valid point, actually, and that's a real important point, which Dr. Bianchi brings up very eloquently. So, Jim?
Yeah, I'd be interested in seeing, because we had this discussion at New Cardiovascular Horizons, how many times do you reopen a ISR case? And so here they've already gone, they've had bypass, both vein and PTFE. But the question I guess I have is, my algorithm is I'll have it, and generally I'll open it once, maybe twice, depending on what happens in their symptoms and everything else. But I just don't keep doing it over and over again. Unless you've exhausted all options and everything else, which is the case here. But, saying going to bypass, how many times will you reopen an ISR case?
Can I ask, though, if this was a CLTI, what would you do, Christian?
Most definitely, now you are switching, and now you can live with the consequences of things go wrong when you are attempting a limb salvage procedure. And again, I think this is a fails times 3. And if he will present with recurrent CLI, then I definitely will probably try to attempt an endovascular rescue, as he has failed already venous bypass. No doubt about it, yeah.
What is important, in my opinion, also to understand why this stent occluded. Maybe if I see where there are a couple of fractures, I don't know if they are so important to create an occlusion of the segment, but this can also prevent the intervention during the follow-up of the patient.
Also, would this be a good case for a PQ bypass?
It could be. And remember that all you need is flow to heal, perfusion to heal, and healing time is different from rest pain or claudication duration, right? We don't need a durable procedure. We need to heal the wound to save the leg. So different timing also.
What about your devices like the PQ bypass, Detour device that's now available? I mean, I agree with you that claudication is not going to, lead to limb loss, but it is still lifestyle limiting. It still hurts, it's difficult for the patient and obviously compromises their lifestyle. Would you lose anything by doing a PQ bypass in these kind of cases? I mean, I don't know who's done them. We just got it into Sinai, so that's it.
You've already thrown the kitchen sink at this person with surgery and endo.
Right.
So, I mean, the concern I always have, which the limited studies show, it's not a whole lot of DVT risk from it. It's a very low percentage, but, do you want to risk that on top of everything else in the claudican? I agree with Christian. Maybe, if possible, adjust. I mean, everyone's not as fit as Christian, so you have to think about what this patient's
And you also have, I think, 2 centimeters you need proximally in the SFA as well. Certainly we're hearing of people going below the knee with detour and everything else, which I think will be kind of interesting. But, to get somebody that's got 2 centimeters above and going to P1 section of the popliteal, that's not many cases in my practice, I know. But certainly I'm interested in doing it for those appropriate ones.
Wir haben beide. Normal?
Andre, how's it going? You heard the discussion, I'm sure.
Der ist normal.
Was a question to me?
No, just wanted to see where you are at this point. We saw you working hard while we were
Okay.
having the discussion.
Yeah. So we said it's very easy, and then it became difficult. So here was a sudden stop here.
So it looks like you have a fractured
wire.
stent or a disconnected
It's very
stent there.
fibrotic
You
here.
stuck the...
Cannot twist the catheter somewhere else. So I decided to go just quickly through the stent here, retrograde, to overcome at least these centimeters here now. I didn't really film it, but I hope you saw it. So now at least we can overcome this part. Then, of course, to continue with our wire from undergrade, potentially we need, is the Draht weg? Or? Another retrograde approach here. I can hear you, yeah?
Yeah, why did you decide to go retrograde from the middle of the stent and not from the lower portion? Because if you have another problem, then you have to punch it again.
Yeah, our experience is, so if it's that difficult at some point already in the proximal part of the stent, you may encounter several other areas where it's similarly difficult, and you have to overcome them again, and it may be also difficult from retrograde. So I prefer, in fact, in these kind of cases, rather to at the end, several retrograde approaches, which is absolutely no problem here.
And in your experience, could be an opportunity to use a balloon from from above to keep the guide wire in the center of the stent to avoid a retrograde access?
Yeah, we have done this occasionally with mixed results. Sometimes works, sometimes not. Potentially, I would prefer to take the go-back catheter in, which could also be, of course, sometimes a little challenging. Here we have this next problem. Of course, here this fracture. We probably need to puncture once again here, yeah.
Oh, man.
Yeah, but
There you go. Looks good.
is this inside or?
Hopefully inside.
You never know. One angulation is no angulation.
Oh, you're good.
Yeah, it looks good. Yeah, there's a question. Yeah, sure, go ahead. Want to try this?
Da sieht's nicht so toll aus.
Relativ nah dran, aber drin.
Hello, Dr. Schmidt.
Vielleicht.
Thank you for your case. I want to ask about which catheter are you using for the retrograde there?
Pacific 340. Sorry?
Which catheter are you
Pacific
using for the retrograde? What you
When you did your retrograde access,
That was a very simple support catheter, quick cross 035 short.
what's
You
your
can
experience?
take anything in. I mean, nothing bleeds here. You can take a sheath in, 6
May not
French,
be on.
absolutely without risk. Sorry, I have to wait for a balloon.
So Andre, it's PK. How are you? Great case. Now that you're dealing with this fracture, the issue here is going to be with the Rotarex. I know you're going to cross this. And are you concerned with running the Rotarex through this fractured segment? Because obviously you have a lot more experience than we do here in New York with Rotarex. We've just started using it, but we've been relatively avoiding using Rotarex in these fractured stents, especially in the fractured segment. I was just wondering on your thoughts on that.
Yeah, actually, we always take the. Oh, that's outside. No, that's not good. No matter whether there's a fracture or not, we take this supera across. No, I have to puncture once again, retrograde. So we never had the problem that we couldn't take the supera out or so. So it is. You have also a button where you can actually make this spiral turn the other side around to release any struts if they're hooked into the catheter. So never has been a risk. Of course, sometimes in these kind of very fibrotic areas, you have to pre-dilate maybe and then continue with Rotarex. But it's completely without risk.
One more question. I hate to be a pain about Rotarex, but I'm trying to learn as much as I can. You said 8 French, 10 French, and 6 French, but you said 8 and 10 for the iliac, 10 for the iliac, and 8 for the SFA. When do you choose to use the 6? Because we've also used the 8 specifically in the SFA, but when do you choose to use the 6 French Rotarex?
6 French we use in native total occlusions of the SFA, for example, if we are not absolutely sure that we are.
Andre, have you had any issues going up and over with the Rotarex? Has anybody on the panel had any difficulty with that in terms of?
There were problems, but
I was telling PK, the only issue I've had is, and it's well known, is that sometimes you get separation of the device, and that's for me a little scary, but recovered it, but one I had to snare, so it's well known, it's nothing,
Yeah, and it really depends on the acute angulation of the aortic bifurcation. It's something to be careful of, obviously.
Einmal bereit?
We also have Jos in the audience. Jos, what's your experience with Rotarex in terms of these kind of stent fractures?
There he is.
This is
It's on.
That is really an issue if you have stent fractures, but also even in segments where the stent is not completely open, you might run into some problems. You hear the pitch going up of the device when that happens, and it typically automatically blocks. And then the only thing that you can do is just pull back, maybe do some pre-dilation first, and then have a go again, or just leave that segment for what it is and try to cross the device more distally, and then debulk also distally. But that is one of the issues that can happen. It also happens with the other devices that they block there. Also with the laser, you have the same issue.
If I could ask the panelists, you know, this is a tough cross if you look. I mean, this is not the typical ISR case we see with a lot of acute thrombus that's easy to cross. So the question becomes, when you do cross, is the Rotarex device going to cross? What's been your experience, Joss or Andre or anyone on the panel?
I think the chance that it crosses is high. It may need some kind of predilation, indeed, that's true. But eventually, I think it will work. I mean, yeah, so stent fractures could be a problem. So, in fact, sometimes around a stent fracture, that effective, unsafe.
So it sounds like he said that he may have to do a pre-dilatation to get it down there. And obviously you'd want to put your filter in first, right, once you cross before you do that pre-dilatation, since you're worried about debris.
Ja, bereit?
Do we know how long the
Eine
symptoms was, Srini?
Judkins-Führungskatheter.
Do you remember how long the symptoms was, Andre? How recent was the symptoms? Or has it been 6 years?
It's been years, is what he said.
So he's tried
6 years.
Well, yeah, I mean, yeah, so the bypass was in August this year and didn't keep open. And therefore, symptoms since then again. But in between, when there was an occlusion for longer times already, yeah, he was very unhappy. He knows the situation. Normalen Judkins.
Christian, if I could ask you, you know, seeing how difficult this case is based on what you've already said.
Patient says no.
I'm assuming you would put this patient on a supervised exercise program, stop smoking.
Yeah,
I assume, you know, hopefully he stopped smoking, but you would obviously push for that. And then if he comes back to you 3 to 6 months later, says, I can't take it, doc, what would you tell him at that point?
On treatment, but I mean, I'm going to be incredibly direct. The natural history claudication, the sibling claudication, yes, the quality of life is incredibly impaired, but I'm telling you that limb loss also impairs your quality of life significantly. So I don't know anybody who didn't get better from stop smoking and exercise program and going to the gym and get your strength. We do this in frail patients every day. We do this in broken hips every day. We do this with ourselves every day. And we feel better when we walk and when we train and when we run versus when we don't. We decondition. So with all due respect, yes, we do make a living out of procedures. All of us do. And there's a right and a high risk. This is certainly high risk that I personally, with my skill set, with the natural history put all together, will try to avoid.
No, I think that's a fair point. Have you seen patients get better when they have significant iliac disease, iliac CTOs with exercise, etc.? And that's a different situation, but good for all of us to know.
I don't want to be the non-interventional interventionalist. I do a lot of interventions, and I think there's a very different ballgame on somebody with autoileal occlusive disease presenting with claudication and somebody with FEMPOP presenting with claudication. But this is a claudicator who has dual segment disease with a single vessel runoff, with a perineal that has only an anterior branch, not a posterior penetrating branch. So, you know, when you compute all those things together, this is a really incredibly high-risk op. And you need a tier 1 operator, and you have one right there. I'm probably a tier 3 operator in the CLT community. So I won't choose to this op, but somebody may, you know, he does, but I would stay away.
So Chris, I mean, I understood what you're saying, but I think if you're able to do it safely, like you said, with a tier 1 operator, would you encourage us to go after these lesions? I mean, knowing what you said about the natural history of claudication.
I think at the end of the day, if your patient completely understood and you can sleep at night knowing that you did everything right, absolutely.
Yeah.
Absolutely.
Okay, I think we agree.
Here's a unpopular question, but I know we're in the advent of DVA. I do a decent amount. Do you think the biggest issue with this patient for the failed bypasses on his endo is no good outflow? So is there a role for that in the future as we go? If he develops into rest pain, would that be a potential?
Yeah, that's an excellent point. And I was thinking about it. Obviously, you can always blame the issue of technical issues in the bypass. I don't know whether distal bypass is a below knee bypass. He has a single perennial runoff. In general, for the TBL,
135 lang.
TBL runoff score, obviously, the lower the score, the worse the patency on bypass, as well as obviously endoluminal intervention. So all these things condition durability of the procedure. And again, you're talking about a procedure that needs to be durable to prevent him from walking for a long, long, long time. He already has shown biologically he's not a durable patient. With all due respect, at the end of this case, it's going to be, I'm sure, perfect. How long this is going to last?
Well, that's what I'm wondering, because I've seen my DVA patients resolve their rest pain. So if he develops into that,
Okay,
maybe getting more outflow at the same time of the intervention may provide some more patency to whatever the above knee is.
Right. And again, rest pain, different indication from claudication.
But I'm wondering if we can move on to, at some point, if you're failing for surgery and endo, he's had several attempts, surgical and endo, maybe we're not addressing the outflow issue.
Well, he has. He definitely has. His pedal arch is also actually compromised. At 2-1, it's a 2A, I believe. It's a single.
Right.
I didn't, so it's only the DP. So yeah, definitely.
So great discussion. Maybe while Andre and his team are working, we can have some of the talks. It looks like we're going to go live to Andre, if we can, please, because it looks like there's been a change of plan in terms of the therapy that he's delivering. Can you hear us, Andre?
Yeah, yes. So
tell us what's happening.
Yeah, so we went down here to that segment, but we couldn't re-enter from the stent into the open segment. And I didn't try very much from above. And you can see also that this wire takes quite a loop here. This is obviously the anastomosis of the bypass. So therefore, puncture here, go in here, wire went in here, but then upwards. And then wire always went here into a bypass. So yeah, we tried with the CTO wire everything actually, and it didn't look like to be easy. Also a little injection, we see this from above here. You can see that maybe from the SFA now we could take the curve here back in. Yeah, but at the end we thought this anastomosis is a little bit too complex. We read the surgical report, but didn't say anything of an end-to-end anastomosis. It looks to me a little bit like one. So therefore we changed our strategy and thought, okay, let's do a bypass reconstruction. So we gave up here to reconstruct the stents here and snared here our wire. That was easy actually to get into the common femoral artery. Wire went here into the catheter. And now we are through. And we can now start with Rotarex. Yeah, a little more complex than we thought.
So your plan now is to do Rotarex and then see where you are at that point, right? In terms of delivering a definitive therapy after.
Yeah, so potentially it needs some reconstruction with stents at the distal anastomosis.
Andre, as you're doing this, which is a great tour de force, what are your thoughts on how to improve the success of this bypass that you're about to fix? Because I think we're going to deal with the same problem in terms of the short-term patency probably, but do you have any thoughts as to your steps once you debulk it and what your treatment plan is?
After treatment, we will have a close look to the anastomosis areas. And if we have luck, it's a problem of anastomosis. And we can fix this here with either Rotarex, drug-coated balloons, stent, and it may stay open.
Andre, it's PK. I'm concerned, with this Rotarex and this, I'm assuming it's a PTFE graft. Are you worried about the graft collapsing on the Rotarex with suction? Or do you think there's enough material in there to prevent the graft from just like wrapping around the Rotarex or get sucked into the Rotarex?
Yeah, with prosthetic grafts, actually, we never have problems with ripping a hole. And of course, it's different with vein grafts. But it helps, in fact, if you go in, certainly you have to observe whether some blood is going into the bag. If not, that means, the arterial wall is really sucked to the head of the catheter. So you have to stop. And then you see blood going down again. And then you continue. So you have to use this kind of stepwise treatment.
Andre, do you ever put a column of contrast in there so you can kind of watch that?
Yeah, you could do this. It will probably not really follow into the graft here from antegrade. So 8 French, the device prevents strong injection. As you can see, it's not really helpful. The most important thing is to really observe whether your bag is filling here with blood. If not, you stop again, you continue again. And if this doesn't help, it may be just a stenosis at the proximal anastomosis. And you have to first balloon this to allow blood flow to follow here the Rotarex into the bypass. And then it works usually. Yeah.
Andre, can you tell us your algorithm? I've noticed over the years you've actually done quite a few passes with the device when you've used Rotarex. Do you have an algorithm in your head in terms of how many passes you need to make? Is it a feel thing? What are you looking at or thinking about?
It's a few things. So in fact, actually we're doing one extensive passage like this here, going a little bit forth and back. And then we take it out and we have a look. And if we see areas with more thrombotic material left, we go in once again, but not for the whole area once again. No.
Would anybody use a different device here? Dr. Finelli, anybody else?
No, it's when you work in the bypass, depends what kind of material. You can also try to aspirate a little bit of the material inside, but it's a pretty challenge.
Yeah, I don't think there's a lot of role for lytics here, and I think there's, if you can't actually remove the plaque and the grumous material, and I think it's going to be very difficult to establish flow.
Jim, would you use Jetstream here?
Well, I don't like opening up old PTFE grafts. There's going to be intimal hyperplasia at the proximal and distal anastomosis, really. They're only going to be thrombus and well-organized thrombus, but, even if I'm operating, I'll put a new piece of PTFE in rather than taking out, trying to open the old one. So I think this is kind of a heroic effort here. I think Jetstream would work fine here, too. Would not use a directional atherectomy device. Laser, because most of this is going to be thrombus, but you're just not going to get that much luminal gain. So I would use some type of rotational device, as you see here, but pay specific attention to the proximal and distal anastomosis. Now, I came in late, but did he have a vein graft also? Was that below the knee?
Yeah, this graft is from 2018, and the vein graft just failed. They just put it and failed very, very quickly. It's an early graft failure.
Right. So, obviously you'd have to know what the outflow was for when they did the vein graft.
Right.
One would have to assume that if they went below the knee, that there's something going on in the popliteal too.
Yeah.
Mm-hmm. Yes, there is.
Yep.
There's a lot going on in the popliteal.
There's a reason why they went below the knee with that.
If we can
I
just,
certainly wouldn't use an atherectomy device in a vein.
so just going down the panel, if you can pick one device that you like to use for ISR, what do you guys pick? Start with PK.
For me, it's Rotarex right now.
Yeah. Kumar,
I do laser.
Dr. Finelli, Christian.
If it's an early percutaneous thrombectomy and then a DCB, and if it's late, I think laser or Rotarex
Passivlaser.
and DCB.
Laser.
For me, Phoenix or Jetstream.
Primarily jet stream with both blades up and blades down. Unless it's acute, then I'll go in with lytics and aspiration.
So it shows you there's just a lot of choices in this space. There's not a lot of outcomes data comparing these different devices, as we know. So it really boils down to operator experience and
Srini, Chris,
preference.
I just want to clarify. So there was a prosthetic bypass, PTFE, 6 to 8 years ago, and then a recent vein graft.
Correct.
Yes,
And
that
more
was
like
my
Dr.
understanding.
McKinney say, the target of the below knee, the vein bypass was a below knee. Yeah.
Yeah.
PTFEs across the knee don't do well.
Yeah, exactly.
Veins above and below the knee do well. But
He's in the above knee PTFE.
So, so Andre, just a question: were you on the on mode as you withdrew the Rotarex as well, right? You were doing both.
Yes, correct.
Wow, look at that.
Okay, just mal, give you an Angio. So, können Sie ihm sagen, nochmal ganz ruhig? Ein. He's moving a lot. His restless leg. But doesn't look too bad.
So, Christian, if this was the initial plan from the beginning, would you be more inclined to intervene, or do you feel the same way? Just so we can all learn in terms of what your thought process is.
When you say the initial plan, you mean about salvaging the PTFE graft?
Correct. Correct.
And again, my mind doesn't work that way because the PTFE graft has been failed for a while. After that, he got an intervention, a venous intervention, which is the standard of care. Why he didn't get that to begin with, I am not quite sure. So in terms of my approach is, why did the venous bypass fail? It was a bad segment. It was a compromised segment. It was a distal anastomosis issue. So you would hope in the surveillance of that, and this is August 2023, right? So it really failed a month ago. I will say that I will try to revise that maybe and rescue a venous bypass. Although when you rescue a venous bypass, the outcomes are actually not particularly good. If you don't detect any technical issue, the outcomes are even worse. So I will say venous bypass, once you put one, you're really committed, like a long-term relationship, to keep it and care for it. And I think I will be concentrating on that. Saving a old PTFE when you have a target distally with a vein, to me, I really wouldn't even consider doing this.
Yeah. So, Andre, I mean, in the interest of time, we may have to sign off here, but what is your plan at this point?
Yeah. So first of all, I think Rotarex nicely cleaned that graft. We need to look close to the proximal anastomosis. Here, I think this is the problem of a distal anastomosis, stenosis. You can see this another angulation, but altogether, yeah, I think Rotarex made so far a good job here. Now we hopefully can finish this all together as a good job. Mal ganz ruhig halten, bitte.
What's your plan for that distal anastomosis? POBA? Are you going to do something else? Stent, etc.?
Yeah, you can see this here. Yeah. I don't know. Potentially a stent.
What stent would you put?
I think I will never more in that case try to open up the SFA, go into the open SFA here. So no problem with bridging from the native artery into the bypass.
Yeah. Yeah, I think if you prep that, Supera is what I would choose here.
Yeah.
That's what I would say.
Yeah.
Perfect.
Okay. Well, thank you. We
Thank you,
really
Andre.
appreciate your time. Two great cases. Thanks so much.